So we discussed emergency contraception method, that was Livonil pill, Elavon pill, and IUCD. Patient present within 3 days, then Livonil pill. If she presents within 5 days, then Elavon or ulipristal acetate or IUCD. Now, next scenario is contraception in postpartum period. Now, in postpartum period, remember that in postpartum period, because pregnancy is a hypercoagulable state, that's why the postpartum period is also a period in which the patient blood is procoagulant or it contains high concentration of clotting factors. That's why COCP combine oral contraceptive pills which contain estrogen, remember that estrogen is also a procoagulant because it increases the formation of clotting factors. So it can lead to thromboembolism. So with estrogen use, there's a risk of thromboembolism, and pregnancy is already a hypercoagulable state. So COCP are contraindicated 6 weeks after postpartum period. So they are UKMAC 3 or 4.
UKMAC 4?
Yes, UKMAC 3 and 4, they are absolutely contraindicated. They should not be used in this period because with the use of COCP, combined oral contraceptive pill, the risk of thromboembolism increases further. So COCP cannot be used until 6 weeks postpartum because of increased risk of thromboembolism. The other contraindication for COCP use is that they decreases the milk production. So if the female is breastfeeding her baby, COCP is avoided in breastfeeding because it decreases the milk production. It contains estrogen, which suppresses the milk production. So remember these 2 points for combined oral contraceptive pills. Combined oral contraceptive pills are UKMAC 3 or 4 within 6 weeks after postpartum period. And they are UKMAC 2 after 6 weeks if the female is breastfeeding. So within 6 weeks postpartum, they are UKMAC 3 or 4. And after 6 weeks, they are UKMAC 2 in a breastfeeding mother. And in a non-breastfeeding mother, they are UKMAC 1 after 6 weeks. So in short, COCP can be used in postpartum period only after 6 weeks. What drugs you can use before 6 weeks in postpartum period? That is POP or progesterone only pills, because they does not interfere with the milk production, and also the risk of thromboembolism is very less with the use of POP. So in postpartum period before 6 weeks, POP is UKMAC 1. and COCP is UKMAC 3 or 4. After 6 weeks, if the mother is breastfeeding, then COCP is UKMAC 2. It's UKMAC 2 because it decreases the milk production. So that's why it's not a UKMAC 1 even after 6 weeks. But if the mother is not breastfeeding her baby, then it is UKMAC 1. Because the risk associated with a COCP is that it decreases the milk production. So less than 6 weeks postpartum, COCP or UKMAC 4. Less than 6 weeks postpartum, POP implants are UKMAC 1. What about IUS, IUD? Remember that IUS and IUD, the devices, they are UKMAC 4 within 48 hours to 4 weeks postpartum. Why they are UKMAC 4? Because after 48 hours to 4 weeks postpartum, the uterus is very soft. So inserting an IUD device, intrauterine device, such as IUS or IUCD, can lead to uterine perforation. So that's why they are UKMAC 4. If the patient want a contraception within 48 hours to 4 weeks postpartum. You can see that intrauterine devices that can be inserted within 48 hours, but after 48 hours to 4 weeks, the chances of perforation increases. So after 48 hours, they become UKMAC 4. Remember this point, that these devices, they are UKMAC 4 after 48 hours till 4 weeks postpartum, because the uterus is very soft in this period and the chances of uterine perforation increases. That's why they are UKMAC 4. So two drugs are UKMAC 4, COCPs, because they contain estrogen, which increases the risk of thromboembolism, already a hypercoagulable state. So there is a serious health risk with the use of COCP less than 6 weeks postpartum. So they are UKMAC 4, IUS and IUD. They are also UKMAC 4 up to 4 weeks, between 48 hours to 4 weeks postpartum, because the uterus is very soft and the chances of uterine perforation increases if we insert these devices. So that's why they are UKMAC 4. So the only option that we are left with are the drugs, such as if the female is looking for a short-term contraception, then we will go for POP, progesterone only pills. And if she is looking for a long-term contraception and presented to you within 4 weeks in postpartum period, then the long-term contraception method that we can use in this period is progesterone only implants such as Nexplanon. So is this point clear to everyone? Why IUS and IUD are UKMAC 4 and why COCP is UKMAC 4 in a postpartum period? IUS, the time duration for IUS and IUD to be a UKMAC 4 category is 4 weeks, and for COCP it's 6 weeks. COCP can only be used after 6 weeks postpartum. Dr. Shafraz, do you want to ask something?
Yeah, I just wanted you to repeat the point about you said if someone wanted to go for a short term after pregnancy during
Uh,
the postpartum period, then that would be POP,
yes,
which is the progesterone only pill.
yes.
And then the implant that you mentioned after, could you please elaborate on that?
The next platinum implant, it also contain, it's only the next platinum implant, the drug that is present in the next platinum implant is a progesterone analog. So in short, we can say that uh, progesterone only contraceptive methods such as progesterone only pills or progesterone only implants, they can be used in a postpartum period.
Okay,
Progesterone only
got it.
pills if the patient is looking for a short-term contraception, and implants if the patient is looking for a long-term contraception. So less than 6 weeks postpartum COCP, you can make 48 hours to 4 weeks postpartum Mirena coil, and IUCD, you can make 4. Remember that usually no contraceptive method is required postpartum for 21 days after delivery. No contraceptive method is required postpartum for 21 days after delivery. So after delivery for 21 days, no contraceptive method is required because after delivery, the earliest period during which ovulation can occur is after 21 days. So if in the exam they ask you about that a patient present to you at 18 days or 19 days postpartum, and she is worried about contraception, then you will only counsel her that no contraceptive method is required for 21 days after delivery because the ovulation uh, only occur 21 days after delivery. So that's why no contraceptive method is required postpartum for 21 days after delivery. So if in the exam a scenario is asked that a woman is worried that she had sex and does she need any contraceptive method, and she presented to you on 18th days or on 14th day or on any day that is less than 21 days after delivery, then on you will counsel her that no contraceptive method is required. So no contraception required 21 days after delivery. What about after 21 days? After 21 days, if short-term contraception, then which is our choice of contraception for short-term contraception,
PUP.
21 days after.
POP.
Yes, POP. Yes, that's right. POP. And for long-term contraception,
That is Nexaplanan.
yes, we only select a contraceptive method which does not contain any estrogen because estrogen is highly procoagulant. It increases the transcription of genes that is involved in the production of clotting factors, and pregnancy is already a hypercoagulable state. So that's why COCP or UKMEC4 within this time period.
What
So
about
after delivery,
Depo-Provera? Can that be used during after 21 days?
yes, Depo-Provera can be used after 21 days because it's also a progesterone only drug. It does not contain any estrogen.
Okay.
So a breastfeeding woman can start taking COCP 6 months after delivery. before 6 weeks or less than 6 weeks postpartum COCP or UKMAC4 because of increased risk of thromboembolism. After 6 weeks and before 6 months, in a breastfeeding woman, it is UKMAC2 because it decreases the milk production. So that's why a breastfeeding can start taking COCP after 6 months of delivery. And a non-breastfeeding can start COCP after 6 weeks of delivery. So breastfeeding, because it decreases the milk production, can start it after 6 months, and a non-breastfeeding can start it after 6 weeks. Progesterone only pills are safe in breastfeeding, so a female can start progesterone only pills, and they are short-term birth control methods. For long-term, I will use Nexplanon. Now let's discuss an example to make things a little more clear. A 25-year-old female is now 22 days after delivery and wishes a contraceptive method that does not include needles. So Depo-Provera injection is also used for short-term contraception, but she is looking for a contraceptive method that does not include needles. She would like to get pregnant after 6 months. So a patient on 20 presented to you on 22nd day after delivery. So the period is still less than 6 weeks, so COCP cannot be used. And she is looking for a short-term contraception. And the only option that we have in this patient is POP or progesterone only pills. Because IUS and implants are for long-term contraception, and IUS are you can make 4 in this period, because up to 4 weeks or 28 days, IUS and IUCD, they can cause uterine perforation because the uterus is soft, so they cannot be used. So if the same patient presented to us for long-term contraception, then the option that we have is implants or progesterone only implants. COCP are contraindicated after delivery for 6 months in breastfeeding. Depo-Provera injection is an injection, so and she's looking for contraceptive that does not include needles. So that's why that's not a good option. Now another favorite scenario of Plab 1 examiner is contraception in a patient with heavy menstrual bleed. So remember that if a woman present to us with heavy menstrual bleed, then IUS is the first line, because IUS or Mirena or intrauterine system, it improves the heavy menstrual bleed. So that's why it's the first line. If the woman present with heavy menstrual bleed and she is looking for a contraception, for a long-term contraception, then IUS is our first line contraception. Tranexamic acid or non-steroidal anti-inflammatory drugs or combined oral contraceptive pills, they can also be used in the treatment of menorrhagia. In which scenarios we'll use tranexamic acid or NSAIDs or combined oral contraceptive pills, that we are going to discuss shortly. So in short, anything that contain progesterone, such as IUS or norethindrone or progesterone injection such as Depo-Provera, they can improve the symptoms of menorrhagia or heavy menstrual bleed. So with heavy menstrual bleeds, these are the options that we have: IUS, tranexamic acid, COCPs, injected long-acting progesterone, there will always be 2 or 3 questions from contraceptive methods, and one of them will be from menorrhagia because it's very common in UK. That's why this question will always be asked. There was a question about menorrhagia and contraception in the previous Plab 1 exam as well. So if medical management above is not ideal, so if IUS, what is the contraindication of IUS? Remember, the only contraindication to the use of IUS in a patient who is having, in a female who is having heavy menstrual bleed is if she is having large fibroids which are distorting the uterine cavity, then we cannot use IUS. So if we cannot use IUS, then the other option we have is endometrial ablation. We will go for endometrial ablation in the option. If the patient HB is low and her family is completed, then we will pick endometrial ablation. So a patient with heavy menstrual bleed, her family is completed, and she is having fibroids which are distorting the uterine cavity. So we cannot use IUS, which is the first line for menorrhagic women. Then we will pick endometrial ablation, which will destroy the endometrial tissue. And the fertility will also be not preserved because of the destruction of the endometrial tissue. So uterine fibroid with distortion of the uterine cavity, copper IUD and Mirena coil, both of them are UKMEC3, because if the fibroids are distorting the uterine cavity, then it will be difficult to place copper IUD or Mirena coil in the uterus. It can get lost. So that's why they are UKMEC3. So a menorrhagic woman presented to you with this scenario, menorrhagia and having uterine fibroids which are distorting the uterine cavity. Her family is completed, her HB is low. Then the only option we have in this method is endometrial ablation. Some more points about menorrhagia. Now, the management of menorrhagia in sexually active females and in sexually non-active females is different. So in young females who are not sexually active and she present to us with menorrhagia, so she is not sexually active, it means contraception is not usually required because she is not sexually active. So if she presented with menorrhagia only, then we will go for tranexamic acid. And if she is having dysmenorrhea, pain during periods, then we'll go for mefenamic acid, which is an NSAID. And if she is having metorrhagia as well, along with menorrhagia or dysmenorrhea, then we will go for COCP. So in a young female who is not sexually active, if there's menorrhagia only, the first line drug will be tranexamic acid. If there's dysmenorrhea as well, pain during menstruation, then we will use mefenamic acid. And if she is having irregular periods or irregular menses, then we will use COCP. So COCP will only be given if the patient is having irregular periods and she is not sexually active. Now, management of menorrhagia. One more point to remember that a patient with sickle cell disease and present to us with menorrhagia, then the contraceptive of choice or the first line contraception in a female with sickle cell anemia who presented to us with menorrhagia is Depo-Provera, because researchers have shown that it reduces the frequency of painful crisis, that is a complication of sickle cell anemia, that is also known as sickle cell crisis, because Depo-provera reduces the frequency of painful crisis or sickle cell crisis through a mechanism that is not known yet. So that's why if a woman with a history of sickle cell anemia present to us with menorrhagia, then the first line contraception or the first line drug is to manage her menorrhagia is Depo-provera injection. Now, in a sexually active female, so as the female is sexually active, so she requires contraception, and along with contraception, she is also looking for the relief of menorrhagia, dysmenorrhea, or fibroids that are not distorting the uterine cavity. How we will manage this patient? Patient is sexually active and she presented us with menorrhagia or dysmenorrhea. And fibroids are not distorting the uterine cavity, then the first line is Mirena or levonorgestrel intrauterine system. But if the patient is less than 20 years of age, in less than 20 year of age, Mirena is UCAMAC 2. So we will go for a UCAMAC 1 drug to control the symptoms of menorrhagia as well as for contraception. Then we will go for COCP or POP or implants. If there is contraindication to the use of COCP, such as smoking, obesity, and history of thromboembolism, then we will go for POP. And if she is looking for a long-term contraception as well as to manage the symptoms of her menorrhagia. So I'll repeat the management of menorrhagia in a sexually active female. If the fibroids are small and they are not distorting the uterine cavity, then the option that we have is Mirena or IUS. And if the fibroids are distorting the uterine cavity, or if the patient is less than 20 years of age, then IUS is not used because the fibroids that are distorting the uterine cavity, for them, IUS is UCAMAC 3. And for a patient less than 20 years of age, IUS is UCAMAC 2. So then the option that we have is progesterone only implants or Nexplanon if she is looking for a long-term contraception, and progesterone only pills or COCP if there is no contraindication to the use of COCP, such as smoking, obesity, or history of thromboembolism, then COCP, otherwise POP. And in female with sickle cell disease and menorrhagia, the first line drug is Depo-provera. So contraception in females with menorrhagia, in sexually non-active females, tranexamic acid, and in sexually active females, we have multiple options such as IUS, COCP, POP, and implants. We have 4 options. So COCP, POP are for short term, implants and IUS are for long term in sexually active females. Now, if the fibroids are small and they are not distorting the uterine cavity, then we will use IUS. Otherwise, we will use implants. If the fibroids are large and they are distorting the uterine cavity, then we will go for implants. And for short-term contraception, COCP and POP are our options. If there is any contraindication of COCP given, such as smoking, obesity, history of hypertension, migraine with aura, or history of thromboembolism, then we will go for POP. Is it clear, everyone?
Yes.
Yes.
Just remember the long-term and short-term contraceptive methods and their contraindication, and you will not get a question of contraception wrong. So contraindication to the use of COCP includes smoking, obesity, thromboembolism, migraine with aura. Another contraindication to the use of oral contraceptive pill is if the patient is having learning difficulties. So patient with learning difficulties, we cannot use oral medications because they may forget to take the medication on time. So that's why a female with learning disabilities, oral medications such as COCP and POP cannot be used. Remember this point. So if a 16-year-old female who is not sexually active, so a female who is not sexually active, now for non-sexually active females, for menorrhagia, which drugs we will use?
Tranexamic acid and
Tranexamic acid, excellent.
acid,
And for dysmenorrhea, which drug?
mefenamic.
Anemic.
Mefenamic acid. And for irregular or menses or menorrhagia,
COCP.
COCP. That's right. In a sexually non-active female. Now let's do the other example. A 31-year-old lady, known case of sickle cell disease. So she is a known case of sickle cell disease, presents complaining of heavy menstrual bleeding. So which is the first line drug for the management of Depo-Provera? Because Depo-Provera will do two things. It will reduce the frequency of sickle cell disease, sickle cell crisis, as well as it will manage menorrhagia. Because any contraceptive method that contains progesterone can help the symptoms of, can improve the symptoms of menorrhagia. So a 39-year-old woman who has completed her family wants a long-term contraception. She has extensive fibroids that distort her uterine cavity. So whenever you encounter a question of contraception, the first thing that you need to look for is if the patient is looking for a long-term contraception or if she is looking for a short-term contraception. So in this scenario, you can see that she is looking for a long-term contraception.
Endometrial ablation.
First, tell me the options for long-term contraception.
Sir, there are the IUS,
Yes,
IUCD,
IUS, IUCD, and what's the third one for long-term contraception?
Nexplanon.
Nexplanon, excellent. Nexplanon is also a long-term contraception.
But in
So
this
in
case,
this patient,
she
yes,
has
in this case, remember that IUD or intrauterine copper device is UKMET2 in menorrhagia because it worsens the symptoms of menorrhagia. So IUCD or intrauterine copper devices cannot be used. IUS can also be not used because it's UKMET3 because the fibroids are distorting the uterine cavity. So we are only left with Nexplanon.
why
So in
not?
this patient, yes,
Why not endometrial ablation? She has completed her family.
yes, we have two options, either endometrial ablation or Nexplanon.
What will be the
Whichever
best her given?
The best given her condition as endometrial ablation because she has completed her family. She doesn't want, she don't want any more children. So endometrial ablation can be done. And if she is just looking for a long-term contraception and she want to get some more babies after 3 or 4 years, and she want to preserve her fertility,
Next
then
plan
the
on.
option, yes, then we'll use the option we'll have for long-term contraception is next plan. So only one of the option will be given in the scenario or in the Plab 1 exam. But if both of them are given and the fibroids are distorting the uterine cavity and the family is complete, then endometrial ablation can also be a right option. So a 16-year-old fit and healthy female presents complaining of severely painful menstrual periods. Her cycles are regular at 28 days. She denies being sexually active. So sexually non-active female with painful periods, what is the treatment?
Mefenamic acid.
Guess it.
That's right. So a 44-year-old female present asking for contraception device. She has completed her family and needs no more children. Ultrasound has incidentally revealed multiple small submucosal fibroids. She is asymptomatic. Can IUS be used in this condition?
Yes, because it's not distorting, the fibroids are not distorting the uterine wall.
Yes, the most appropriate contraceptive device is Medina or IUS because the fibroids are small and they are not distorting the uterine cavity. Though she has completed her family, but remember that endometrial ablation is a surgical procedure and in which the patient endometrium is destroyed. So that's why Mirena US or Nexplanon are still our choice. Now another important topic, female with a history of someone asking any question? Dr. Asia, do you want to ask any question?
No, sorry.
Okay. Okay, so our next topic is UK